session of the Ohio State University Nights-Unger Center ECHO on evidence-based psychotherapy for adults with intellectual and developmental disabilities. We'll hear from our expert lead, Dr. Andrea Witwer, on evidence-based interventions. Dr. Witwer is a clinical professor in the departments of psychiatry and behavioral health, as well as psychology. She is our director of the Lind graduate program, as well as the director of training and outreach here at the Ohio State University Nights-Unger Center. Our learning objectives today, we'd like you all to be able to identify evidence-based psychotherapeutic approaches for adults with intellectual and developmental disabilities, to understand adaptation of interventions for cognitive and communication needs, to evaluate the use of manualized and modular interventions, to integrate multimodal strategies that enhance engagement and generalization, as well as to monitor outcomes and adjust interventions based on client progress. This time, I welcome Dr. Witwer to the stage as she transitions the slide view on our culminating session on evidence-based interventions.
Hello, everybody. It's great to see you all again. I'm going to put some camera over here so I can actually see some faces while I'm talking, because I like to get some feedback of your faces while I talk. That's a tall order. There's a lot of things in that list that Andrew put for our objectives, and I only have 30 to maybe 40 minutes, depending on when Andrew pulls me off the stage. So we're going to go through it. I also renamed it a little bit as I was going through it. It's evidence-based interventions, and I'm also going to give you all some evidence-informed tools. So evidence-informed in that it's based on literature, but the actual tools themselves have not been necessarily tested in a clinical setting. But I think as we've learned, as we've gone through all of these sessions, there's a lot of great information out there. The knowledge that we have as a field in psychotherapy for this population is really growing. So I think, how can we take what we know and use it, use those evidence-based interventions, or when they don't exist, use evidence-informed tools to help inform that. So just kind of a quick little, what is the state of the research? We did a large systematic review, gosh, it's been about 4 years ago now. Really wanting to look at this, there's been a lot of studies. Maybe we're going to be able to find some very clear interventions that we can map onto specific diagnoses to be able to provide some types of consensus treatment guidelines. And what we found is that there is a lot more research on there, and some randomized controlled trials that have positive results. The challenge is that with these studies, there's so much variability in what the treatments were used. Were they manualized? Do we really know what they did? Did they describe it? What types of folks were they doing this on? What were the assessments they were using? So when we look at that, there's these meta-analyses out there that say, yes, psychotherapy is effective. There's this, seems to be the overwhelming technique that has the most effectiveness is CBT. There's some noise and some signal around mindfulness and some other things. But the challenge is that we still don't feel really confident in this data, such that I can stand up here and be like, if this is your client's diagnosis, you should do exactly this treatment. I think it's kind of cool that I get to go after Dr. Raleigh Roberts, because she kind of set the stage this way, right? So she's like, this is what we have some research for. We have some research for this. And then this is how you can put it into practice in your practice with your clients. So that's kind of where our group is at. I'm going to talk a little bit about our process to understand what the research is telling us right now, and then what that means for clinicians when we kind of look at some of those high level things. A lot of this might be a little bit of repetition, because really this whole series was set up to kind of model the different things that we think need to be parts of the components of therapy. But yeah, hopefully you'll find some useful clinical nuggets and pearls is kind of my goal. One of the things just to make you aware of when we think about treatment, having guidelines, practice parameters, all those things can be really helpful for us. And the American Psychological Association relatively recently updated their guidelines for the assessment interventions of persons with disabilities. And that can be a really good guide if you're struggling with something ethically. I know we have a lot of seasoned clinicians on here, but we also have some newer clinicians. It talks broadly about all disabilities, but does have some specific things related to intellectual and developmental disabilities, and a little bit on autism as well. So that's out there, but our group really wanted to dig a bit deeper in helping to provide more assistance to folks. So I'm going to talk a little bit about the research that we did over the past 5 years. The research that we've done has been a part of a NIDLR grant, which stands for the National Institutes on Disability, Independent Living, and Rehabilitation Research, really working together with our Learning Collaborative, that is a group of researchers that have helped to provide expert advice to us, as well as our Disability Expert Experience panel. You'll recognize two of those folks. Christine Brown is a co-chair on that, as well as Ashley Poling, that have helped us think about how do we answer questions related to measuring the mental health of adults with intellectual disability and understanding what best practices are around treatment. So the way that we decided to go about this is to really start to dig deep into the literature. And we can't tell you you should use CBT for anxiety and behavior activation for depression. But what we thought we could do is provide practice guidelines. What are the different components that seem to be showing up again and again in the literature? What do we know about what people with ID and autism think about these practices? How are clinicians across the country using practices? And then pulling that all together to get us a practice guideline that could help with folks. So I'm going to kind of weave this, I'm going to go faster through this stuff because we're going to dig into the deep. We did a scoping review of all of the treatment literature that looked at treating mental health conditions in adults with ID and pulled out themes of things that were happening over and over again and things that we thought we could help to provide guidance to existing clinicians and that could help us as we develop randomized controlled trials going forward. So some of these might look really familiar, right? We've talked about a lot of these over the course of our sessions, and I'll dig into those a little bit deeper. We took those and we took it on the road and we did focus groups with both adults with ID and their caregivers and came up with themes that were important to both groups. It was really cool because if you look here, they aligned really nicely. There's the rapport building, right? So we heard about that when Emily Carey and Justin Wallace talked about that, using interests, the actual therapeutic process, those accommodations that Jesse Green and Andrew talked about. How do we involve support people and just some other pieces. So we took all of that together and that resulted in our practice guidelines, which is really a guide that takes folks through the different things and some practical suggestions, some links, other things that can help clinicians as they're navigating through a different type of client, maybe someone who doesn't work as much with folks. So we have that one resource, which we're really proud of, and we can provide the link to that in the chat for sure. But we wanted to take it a little bit farther. So what we've also done is developed clear language versions of those mental health therapy guidelines for adults with ID to read so that they can understand what their therapists could be doing. And then we took it again. So that's our evidence, like our research was this part article and the focus groups. And then this practice guidelines is one of our evidence-informed tools. And then this is our clear language version of it. And then we have the mental health therapy toolkit. That's another one of our evidence-informed tools where our disability experience expert panel said, well, this is great, but how do I use this when I go in with my therapist? So we had them develop a communication tool where they could communicate all of their preferences around these topics before they go into a therapy session. So it just provides a ability to do a little bit of a communication and level setting with the therapist. We then took our focus group research and developed some other therapy tools. So this could be things like a therapist checklist. So things to just be thinking about as you're planning your session. What should you be thinking about as you start to walk into a session with person, as well as some, if you look on the therapy helper sheet, in addition to the preparing for sessions, there's some really cool diaries for clinicians to use with their adults with ID, like summarizing what they worked on during their session. Also things like, what do I want to talk, a planning sheet for the adult with ID? What do I, like, work through with the support person or others? Like, what am I going to talk about? What am I going to do? So really just some like practical tools that, based on what we heard from different folks around within the focus groups and with our expert experience panel, that seemed like they would help therapy. So again, regardless of what therapeutic modality you're using, we try to make them trans treatment, so that it would be able to be used by different types of folks. So when we think about how do we put some of these evidence-based practices that we heard from, that we put in our practice guidelines, into practice, my colleagues Emily Carey and Ashley Poling did a really cool presentation where they pulled our treatment guideline and pulled in some of the research of the different articles that we found and gave some practical suggestions to folks. So I think some of these things we've talked about a lot already, about involving support people and how to do that, who it's going to be, but being kind of thinking about all of these topics that we've talked about already. I'm not going to spend a bunch of time here. But I think important that we're thinking about how we include support people. It might be within, a separate support group for them. It might be sessions to teach things to caregivers. We've talked about that and other pieces. We heard quotes during our focus group. So some clinicians say, I distinctly separate what are your caregiver goals in being in treatment and make theirs separate. I'm not going to spend much time on this because I know we've already talked about this. Thinking about accommodations and therapies within support. So wanting to make sure that we're individualizing it for folks. I think that's one of those other pieces we heard in our focus groups. It was like this wonderful woman who was like, I felt like the woman knew every autistic kid that came through needed this. And so I know from talking to my friend, she did the exact same thing with me that she did with everybody else. And really just thinking through those pieces. But how do we do that, right? How do we use some of those pieces? And so this is where my plan is, right? So hopefully this isn't too disjointed, is what are the resources to help you do this? And there are some really cool manuals that have basically done this adapting for you already. So when we look at, there's Andrew Jahoda, who is just a force in the field, wrote a book called Cognitive Behavior Therapy for People with Intellectual Disabilities, Thinking Creatively. It's great. It's more of a like book to read and help you think about what you might want to do. It's not super prescriptive. But then the same researcher has developed a behavior activation intervention that has some initial data of its effectiveness, and it's super cool. It's publicly available and free through, he's in Scotland, so it's through the NHS over there, and it's set up to be an intervention that's done with the adult with ID and their support person. There's a ton of great visual supports. So if you're interested in doing behavior activation with an adult with ID, I recommend you check it out. If you're not, I think it's just a cool way. They've spent a lot of time trying to develop materials that are clear language focused and all of these things, that it can be very helpful. There's also some evidence and some different treatments related to mindfulness-based cognitive behavior therapy. And there's some links there, as well as we know that, as Dr. Riley Roberts talked about, some adapted trauma-focused CBT that has been out there. And then dialectical behavior therapy. Again, not a ton of research on it with adults with ID, but Julie Brown has a book that shows some of the worksheets, some of the other pieces that you can use. So definitely recommend that. Thinking about another intervention that has some decent, robust information. Most of the robustness of the soles of the feet intervention is related to more aggressive behavior versus specific mental health conditions. But it's been used with a lot of different ranges of folks and different levels of functioning. It's kind of nice because it can be just something you have with you all the time, is your feet. Um, and it just works, as you guys know, just being able to direct folks to focus on their feet. They found it to be helpful in maintaining people in their employment, place of employment, and to reduce aggression in multiple settings. Some other different things to think about with accommodations and supports and visuals. We've already talked about the importance of having handouts in clear language. The research has some cool tips. So using a PowerPoint presentation to help provide those visual supports as you're going through content. Using a whiteboard and drawing diagrams. Some of the researchers have done that. Michelle talked about event mapping. So doing that, having a flip chart that you can just go through and go through things. Thinking about with those mood check-ins, having different visual support instead of just saying, how are you feeling? Having a nice visual support in place so that folks can look at this and know we've used colors with these check-ins before and other things. Having something like a visual that shows or some type of a physical prompt to help someone through their breathing has been used in some of the research. This is one, I always have this one here when we were doing our focus group, we were asking our participants about what was used in practice, and we had this as like a prop. And we had multiple people that said, oh, I've used this before, it's great. So it's one of my like favorites. It's like one of those nerdy moments where I'm like, I literally pulled this from like a research study and they have it there. But helping use something like a traffic light to help them think about, is it true or helpful? Right? Is this a red thought or a green thought? What a cool way to help make it concrete for folks. So I think this is just one of the nice examples that's out there. Okay, other cool tips. Auditory, maybe some of you do this, recording audio to be sent home with clients. We had one research study that did that, recording it onto their phone. Having yourself reading the forms aloud to a client. Maybe a client does have a reading level that they could read them, but they find it more helpful for you to read through what's going on. Some folks liked the video visits, some folks didn't, but all of them said having closed captioning on if you're doing a telehealth visit was incredibly helpful just to help with that processing and doing that. Thinking about doing that multi-sensory where you've got maybe visuals and movement, visuals with auditory, trying to kind of get some of the different modalities in place because we know everyone learns differently, right? But specifically, a lot of times adults with AD, they might have different ways. They might be able to tell you which one they prefer. They may not. So having them kind of try out some of these. This is kind of a cool one. It's the stepping stones activity where they wrote goals down on a note card and put them on the ground and created a path to the goals. So it's literally physically showing the client there's a stepping stone from one to another. I put this here. This was one of these studies that I was like super excited about. They have the most research. They've done multiple randomized controlled trials, seem to have good effect sizes. It's basically kind of like an online computer game that folks would use to help them think through things. The challenge is they never made it publicly available to anyone. But I think understanding that sometimes those interactive games can be a nice way to teach a client. Again, tricky. We don't have the research with all of the different apps that are out there, but if you're struggling with someone, maybe something like this could help. Here's some of the other things. So a game, which is interesting because sometimes I went back and forth on games. Like, will people feel like it's too infantizing or like they're being treated like a kid? But we heard from one of our DEEP members that, oh, she's like, my therapist does it with me all the time. I love it. And even our adults with ID said it was helpful. We're trying it in our own treatment study right now, and our expert panel really liked the game and thought it as a nice interactive and different way to stay engaged. You can see some other diaries. And so maybe your average worry diary might be a challenge for some folks, but thinking about having something that's more simple, some different visuals, trying to break it down, such as Douglas and colleagues did. Already talked about simplified language, but some different strategies that have worked, maybe working on building a social story with the client that's appropriate to their age level, modeling, a very important thing, either with you and then maybe with their support person that's around, and that role play can also help with that. We got a lot of tips on ways to help folks generalize what was happening in therapy outside of therapy. So things like a silicone bracelet that they could wear or a note card they could put in their pocket. Again, recording the audio with different instructions. So some of those different things can be really helpful as well. All right, thinking about the therapeutic process, I think one of the most important things that we heard was the need that there's going to need to be more time teaching those prerequisite skills. So this is stuff from as basic as what is therapy? You think about our adults with ID, they're in a lot of team meetings. They meet with job coaches, they meet with all of these different people. They have social workers, caseworkers. They may not know what therapy is. So what is it? Their support people may not know what therapy is. And what's an appropriate expectation for therapy? So you really having some of those orientation at the very beginning where you're laying out what is therapy, what is it not? What does your relationship with your therapist look like compared to other people? Whose roles are what? I think a lot of that, like, it needs to be longer, right? It might need to be more than one session, but so important. And what to expect. I think that's something we heard over and over again from clinicians is that a lot of times the support people had unrealistic expectations. And I think we've heard about this as we've gone through our series, but really what can therapy do? What can't therapy do? Some of those pieces. The other thing is really just devoting a lot of time into identifying like the behaviors and the emotions and those feelings pieces. So really trying to help folks do emotion recognition. They found it really is helpful to break those things down into that step so that they can actually then process the emotions. First, we have to make sure they can identify them, that you're using the same vocabulary as them, and that they're support people. Everybody's kind of on the same page. And then really explicitly teaching the connections between thoughts and feelings. Understanding that the thoughts, feelings, behavior triangle might be too complex, and it might need to be a bit more concrete than that. The other thing, and I know we've talked about this a bit, but it's just always important for us to revisit, is also really not forgetting about physical health and primary care. And really, with all of the clients that people work with, it's important to keep that biopsychosocial model in mind, but really, really with our folks with ID, I think we hear from them, they have multiple medical providers and multiple team members, and everybody's working on different things. And some medicine for their diabetes might impact their behavior, or they might have a seizure disorder and have some challenging behavior related to around their seizures are. So really understanding all of the different potential predisposing factors that might be going apart, as well as those psychosocial pieces, right? What's going on in their environment? What's going on with their roommates, their supports, their family, and really understanding all of those pieces together with the other types of potential, protective factors that there are in place. They may have a fabulous team around them that can help reinforce their homework, whereas other folks may not have that. So really trying to think about those medical conditions as well as all of the aspects related to that biopsychosocial model. So some other resources to think about are, as I said, there's the Beat It and Step Up. Also on this website is the Glasgow scales, which are, there's an anxiety and a depression scale for adults with ID that have self-report versions. So it's kind of a misnomer. As I've talked with the developers, it's called a rating scale, but they've told us you need to do it in an interview form with the adults with ID, but seems to have the most evidence as being helpful in both characterizing and measuring treatment over time. Also, I gave you some of those like clinician resources around manuals, but also wanted to give you, there's some nice, if you're thinking about like, how do I change things into plain language? I feel like it's way easier now that we have ChatGPT. ChatGPT, if you don't know, is a fabulous tool. If you're trying to figure out how to describe something and you want to describe it for an individual with an intellectual disability or a moderate intellectual disability, you can ask it to help you. And it uses a lot of these best practices. I would say, I think the NIH site and the Center for Plain Language are also good resources just to make sure that ChatGPT is nailing it the way we want them to nail it. But I found it very helpful in helping me even just kind of go through the thought work. Like I am trying to describe this, why behavior activation works for someone who's depressed. Like explain it to me. And then like seeing what chat explain it, in the level of like, someone with a second grade reading level, right? And some of that stuff can just help you figure out and a little bit of a self-check, right? I think that's the other thing, right? We go into therapist speak, and we've heard from adults with ID that when people go into therapy speak, sometimes their eyes just, they're like, yeah, I stopped paying attention because they're not really talking to me. They're just giving me a bunch of their jargon. So I think I only went like maybe 1 minute over, but hopefully time for questions. In the slides, I have a bunch of the resources and some links. If anyone would like any of these articles and you don't have access to them through the university, I do. So I'm happy to help link you with those for educational purposes. And I'm just going to also acknowledge, as I said, most of this work was done as a part of our NISUNGER RRTC project, which is led by Susan Haverkamp and is really supported by our Fabulous Learning Collaborative. And then I'm ready for questions.
Great. Thank you so much, Dr. Whitworth, for that overview of evidence-based practices. Really appreciate the specific resources, including those manualized treatments. I'd like to open it up to our community for any questions that came up for you or insights that you would like to echo out to the other community to emphasize its importance. I see Justin.
Yeah. What's a good way we can make sure we're balancing using some of the tools and resources that you just shared, Dr. Weber, with making sure that we're not infantilizing folks with intellectual and developmental disability, because that's really easy to do.
Yeah. I will say that all of the things available on our website were informed and very carefully reviewed by our adults with ID on our disability experience expert panel. So that's a piece. But I think some of it is making sure you're asking their client their preferences, right? So what some might say that using Thomas the Tank Engine is infantizing, but if my client who's a 20-year-old young man who adores Thomas the Tank Engine still and asks, and it's something that he loves, maybe I want to use that, right? So I think it can't be like this clear cut that like, oh, you can't use X, Y, or Z because that's just for kids. I think it's got to be a conversation with the individual, with their caregivers to make sure you're kind of, and understanding where that person is, right? But yeah, it's hard. I think it's just checking in. Like, what do you think? Some people might be like, I don't play games, they're for kids. And then you're like, all right, no games. I think you just have to, and that's why it's hard, right? Because you can't, like an evidence-based intervention is tricky that way.
Hey Justine, this is Ashley. Can you hear me?
Yes.
I could vouch for Dr. Whitward. We all looked over some of the documents and stuff. Some of it we did. I can't speak for everybody on my panel. We went over the documents they brought over, everything. Some of it was a little childish. Some of it we did give our inputs like, hey, let's make this more age appropriate. And I agree with her. Sometimes if that's their preference, we have to do it. So I want to vouch that everything they have shown us, we have seen over the years. This has been going on for over 7 years. So this is not my first rodeo. So I've kind of gave that point to the REIT.
Yeah, thanks, Ashley. I appreciate the nod. And she's talking about we are now currently studying an exact group-based anxiety treatment. And so our deep looked at all of our slides and we're like, what do you think? Okay, not okay. And they helped us to realize, maybe don't use this word, or hey, this picture, this looks more like a kid than an adult. Don't use this picture, and some of those things, which is incredibly helpful.
Well, we're waiting for any additional questions, and feel free to use the chat if you like. One thing that really stands out for me is all of these effective practices for this specific population are also, I think, right, generalizable best practices for the general population. And by applying these practices, not only can we improve mental health care for individuals with intellectual and developmental disabilities, but for all of our clients. And so I want to keep that in mind as well. And in line with that, I think oftentimes we in all of our interactions and relationships, we overestimate or assume other people's knowledge and skills and abilities, including recognizing my own emotions and how they're expressed. And Dr. Whitwer, you had even mentioned so often we have to go back to those basic building blocks of recognizing emotions, not taking for granted that someone knows what it means to be sad, mad, and happy. And there's this diagnosis of alexithymia, where there's this inability to recognize one's emotions. And interestingly, it's kind of common in the general population, but even more prevalent in the developmental disability community. So I'm wondering, with that in mind, Dr. Whitworth, maybe just remind us of those effective practices or strategies, maybe when we're first engaged in developing that rapport with the client on gauging emotional awareness and understanding and tools that maybe can help build better understanding of what emotions are and how they look like or what they look like.
Yeah, and I think, most therapy will start with some type of a psychoeducation, and that's a nice way to just kind of make sure you're using the same vocabulary. And I also think that's where those anxiety diaries come in, because you can start to see what are they recording and how are they describing it can help you really start to understand where is their level of awareness. I think some of our therapists out there might have better answers than me to kind of how do you dive into that with the client. But I do think it's just nice, like you said, everyone approaches it differently. They have different background. So making sure you've got some of that psychoeducation about okay, this is why we're talking about it. And what do you know? What do you think? How does it go? I see Patrick. Let him chime in. And Anastasia.
Can you hear me?
Yes.
So one of the strategies that I have found beneficial in accurately naming emotions, or at least introducing it, because a lot of times any sort of distress is initially interpreted through an anger lens. I'm angry about everything, even when I'm sad, when it's sadness actually that I feel. And I find using opposite action in DBT, dialectical behavior therapy, opposite action, because it connects the emotion to a behavior for folks. And I can step through folks. Like if you're sad, what's the behavior connected to that? Oh, I cry. if you're angry, do you see how that's different? What do you do when you're angry? You might get so angry that you cry, but that's not the initial. So, and maybe this is a plain language thing, but sort of starting with the emotion, then working backwards to sort of have them talk about how did you act when you felt that way? And then using the action to help inform the emotion, if that makes sense.
Yeah, I like that. It's kind of like pulling it, tying it to that behavior very early on. So then you can kind of go back to that to kind of start teaching in the moment with the situation, some of the other pieces.
Because a lot of them, it's all anger. Everything's anger.
Yeah, Anastasia?
Yeah, so thank you. I loved your presentation. A lot of really good stuff in there. And one of the things that you mentioned was, measures or surveys. And that's one thing that I've encountered, specifically with autistic patients who I've worked with. The PHQ-9, the GAD, it does make sense to me. I don't get it. It's a useless tool. And so I'm just curious if you can talk more about using measures and how you track progress and share that with the patient or the client.
Yeah, it's an ongoing challenge, I think. And we, our group, as I said, I've been kind of the therapy person in the therapy study. There's a lot of work being done in measurement, especially self-report measurement. There's a bunch of measures out there that ask caregivers to report on people's anxiety and depression versus like that self-report piece. And so, so I think we're like kind of in the infancy. For adults with intellectual disability, like I said, the Glasgow scales seem to be the best ones. They really, if you look at them, they try to make things much more concrete. The rating scale is less complex. It's like a 3-point scale. So they tend to help, especially our folks with ID. There's one floating around that has pictures. Ironically, the developers told us in our research study we weren't supposed to use the pictures, made us sign something to not use the pictures because it hasn't been validated that way. But I think the pictures would help you clinically. So if you, but I didn't say that. But if you Google that, some like visual supports, but regardless, the Glasgow scales, I think are a little bit more complex. And able to kind of use with that population. The autistic population, it might be good for some of them. The challenge is it is very much for folks with ID. They might think it's too basic for them, but at the same time, a lot of, like you said, a lot of those other measures, folks, there's not a lot of great data. We don't have data, I guess, is what I'm saying, on like, this is the best measure to use. I think if one colleague that used the really short one, the GAD, and said that it was okay in her autistic non-intellectual disabled, but it sounds like you've had experiences where it's not as good. I think, well, and you speak to so Andrew talked about alexithymia. We know there's really high rates of that in autistic individuals. So we actually at our meeting on Friday had a huge discussion about is it alexithymia? Is it understanding what an emotion is? I think it's so hard to be able to do that. So I think using those tools to help make that common language, but in some of the Glasgow skills and treatment studies, they have shown change with them there, but I don't know, so I think they could be an effective tool, but I don't have more guidance for you than that. I don't know if others on here do or other thoughts.
But I think your recommendation, right, even though these are validated tools for the general population, you would encourage us to both modify those instruments and possibly even fill them out in, I would say, non-conventional ways, so to say. You might fill them out with the person or with a support person in combination as a team.
Yeah, okay. I dive a little bit as I say, yeah, kind of. We always want to use validated tools and use them in their validated ways when they're available. The problem is that they're not available always. I think the good news is it's cool. You saw Dr. Molly Roberts, there are a lot of trauma tools out there that are freely available. There are these Glasgow scales, some of those. So I think I would say first look at what's out there and try to use something that's been adapted and at least has some research and validity to it. And then if there isn't anything like that, then exactly that, Andrew. I think sometimes it is just instead of handing it to them and expecting them to fill it out, it's doing it like together collaboratively, talking about some of that scaling. So if you like think about maybe even just having like the smiley faces or that a little kind of a lot, like visual support with the 0, 1, 2, some of that stuff can be. So I feel more comfortable. I think it's just like with a lot of things we do, least to most modifications. But it also is what you wanted for. So if it's about starting that collaborative conversation, then maybe it does just end up being like a starting point to kind of anchor you.
Thank you so much. I'll pause to see if we have any final questions before we transition to our case. I did see there was one request in the chat for access to the articles, if that's an option.
Yeah, so a few things. All of the ones that we've done, we have made them purposely open access. So if you go to the website that Andrew shared, there's links to not only our clear language products and our therapy tools, but links to those articles as well. And if there's another article that I cited that you're like, oh, I really want to lay my hands on that, then I think email me and I can do that on an individual basis. Since they're copyrighted, we can't kind of send them out to the whole group. I don't know, do I have it looks like there's like there's one more question from Patrick in the chat. Do I have time for that or should I?
Yeah, let's take it and see if
Okay.
there's
I think the data on therapy, like length of therapy, is challenging. A lot of them say it's going to take more sessions, but then there's others that are shorter amounts. There's not really clear evidence. Even the length of therapy. Some folks said you need twice as long. Other people said it needs to be half as long. I think it's so individualized that it's like across the board. When I looked at the research studies, there were some that just went into perpetuity and never had an end. 20 sessions, 16 sessions, 10 sessions. Yeah. I wish there was better info. Again, right? We're just not there yet. Hopefully we will. The data's getting there. Hopefully in 10 years when Erin, my grad student, decides she wants to look at this, she'll see some good data. You like that, Colin, Erin?
Yeah, to that point though, right? It is so individualized, and that's kind of
Yeah,
one of the difficult things about this field, or maybe even with everything, is that every individual brings unique
Yeah.
strengths and skills as well as challenges. And right, like you said, it could be more sessions, but it could be more shorter sessions, fewer longer sessions, and really, building that rapport and getting to know a person, what works best for them is a great way to go. Well, I want to thank you for your presentation today, but Dr. Whitwer, I also want to recognize and applaud your leadership in this entire project. This is our fifth series, and what a great way to end this project, bookending an overview of evidence-based interventions with your beginning session of this series, foundationally the ethical and moral imperative for improving mental health care for this population. Thank you for being a leader in this field and guiding us through this series. We really have enjoyed learning from you today, and I'm sure the community feels the same way. So thank you so much. It's very moving. And again, thanks to all of our community members for being a part of this journey with us together and really being committed and dedicated to advancing inclusive mental health care for this population. At this time,